We had a really interesting session, and my role was looking where radiotherapy fits into this complex pathway. We've got a new study, the CheckMate 816 study, showed groundbreaking results in neoadjuvant therapy with a combination of chemotherapy and immunotherapy. And on the background of that, last year we had the Pacific study, again showing groundbreaking results looking at the addition of durvalumab to chemoradiotherapy. And these should be two very distinct populations. One is unresectable disease with radiotherapy, and the other is resectable disease with surgery. And the key question is, now we have both these options, isn't it? Does that change who we should operate on? Does it change our MBC structure? And that's a difficult thing to know in this current situation. So I went through some case scenarios trying to get a feel for the audience, what we might do and what we might not do. And I think there's a fair consensus, and I think the consensus at the moment was we should not change our current practice in terms of surgical practice. But as we get more experience and perhaps some better biomarkers to work out where I have a fantastic response in neoadjuvant chemotherapy, maybe that boundary of what's operable may change. The key other questions is, where does radiotherapy still have a role even in those operable patients? And we know the current NICE guidelines from 2019 suggest that chemoradiotherapy should be considered for patients prior to surgery. And that's not done very often in UK practice, partly because it makes the surgeon's life very difficult after radiotherapy, though we do it for certain tumours such as pancreas or superior skeletal tumours. And there's good evidence for that, albeit very old evidence, show very high rates of pathological complete response, not a bit higher than what we saw in the CheckMate 816 study. However, that was pre-PET, pre-PD-L1 testing, and if you've got a high PD-L1 expressor, do you want to miss out on the opportunity of giving immunotherapy? So the real debate at the moment where we would do for inoperable superior sulcus tumours. There's a little bit of concern, although the numbers are small. What do you do for those patients who might progress? And can we salvage them with radiotherapy if they're not surgical patients, or if they're not fit enough? And I think a little bit in terms of trial, that the scan to make that final decision was quite close to surgical dates. And I had a little bit of nervous about how we might do that in the NHS, and whether we should scan a bit earlier to give us a bit more preparation to pick up those few patients who might not go progress to surgery, and we can offer another curate option. And then after surgery, there's a lot of debate in the radiotherapy community what we do for N2 disease. So people who've had an operation, had chemotherapy, should we be giving radiotherapy in the N2 setting? And that debate's been going on for decades. And there's emerging data suggests that in randomized trials, radiotherapy for resected N2 disease doesn't improve survival, but it may improve local control, but they may come as a cost. So the Lung Art study suggested that maybe some increased cardiac toxicity, so we have to be very careful interpreting that. And again, these are patients who didn't have immunotherapy. So will that make it better, potentially the combination with radiotherapy and immunotherapy, or could it make it worse and make our toxicity worse? And the final thing is what to do about resected margins. So if it's a positive margin, we standardly give radiotherapy. Again, how safe is that? We don't know. It probably is reasonably safe, but again, these are unanswered questions that we need to find out going forward. So I think the take-home message is really exciting. For our patients and for us, we've got some brilliant treatments. There are some groups of patients with what we debate, but those in the middle, that debate will continue, and we need to try and work out how we navigate that for us and our patients.